We're right a little past the hour. We're going to go ahead and get started. Welcome everyone to our second session of the Project Echo series related to understanding and addressing our increased institutionalization of individuals with intellectual and or developmental disabilities, and particularly in West Virginia. For those of you who were able to join us last month, we really appreciated the active discussion. So we're going to continue with that model. The beginning, Dr. Clayman's going to give us some background information and some from his experiences. And like last month, we're going to have a case. Please feel free to use chat to get yourself off mute, contribute however way you want to in the discussion. We value that. Please remember, until that discussion or you have a question or comment, please use mute while we're on here. We are recording. Closed captioning is available. You should have a menu or a button at the bottom on the menu bar. If you have any issues, let me know via the chat. Also, we're giving certificate of attendance. So please put that in the chat, or I can follow up with you by email after the fact. And last, but definitely not least, let us know who you are. We want to see who our community is on this session. So give us your name, your affiliation, a little bit about yourself in the chat while we get started. Okay, and so with that, let me get our slides situated. Today we're talking about measurement and functioning. And again, just to review, the first 5 sessions of this series are meant to be general by design, getting us acclimated to this topic. And then this series will not go away after these 5 sessions. We're going to dig deeper into those. If you have any ideas, thoughts about conversations that must take place in this area, please send us those. The planning committee would value that greatly. All right, briefly today, related to measurement and functioning, we're going to describe and illustrate how intellectual and or developmental disability is measured, compare and analyze the different ways it's measured, and we're also going to talk about the potential pitfalls as well as strengths that we cannot ignore, should not ignore in this whole measurement and functioning process. So with that, I'm excited to introduce Dr. David Clayman. He's a clinical and forensic psychologist, has a great level of experience in both the forensic side and the clinical side, obviously. Currently chair of Dangerous Assessment Advisory Board and Multidisciplinary Diversion Study Group. He's also going to share, we're going to dip into some policy today with some exciting policy efforts that are going on in West Virginia. With that, Dr. Clayman, I'm going to turn it over to you.
Good morning. If I start coughing, I just had spicy soup, and I never know how it's going to start with me coughing. When we started talking, one of the things I just want to let you know is that I feel super fortunate. The reason why on the intro, I had the DAB, which we call the Dangerousness Assessment Advisory Board. From that evolved last year Senate Bill 232, which was requiring us with a participant. This is how we got together with Leslie and some other people, at least 18 mandated participants to discuss diversion of 4 at-risk populations from the adjudicatory system, and even how do we deal with them in and out of the mental health system like SHARP and the other hospitals. And luckily for me, I fell into ECHO and a couple other community-based undertakings, and IDD became, probably because of Mike Folio, who is with West Virginia Disability Rights, with Bob Hanson, I guess, who was on last time. They've really taken the IDD issue in its larger proportion. And I'm talking because my job as the chair of these committees is from the forensic side. And we'll kind of be touching on that, how it's a little bit different than the clinical as we go through. But when I started looking at ADD years ago, the first thing that came up to my mind was autism. Well, autism wasn't autism spectrum, because we had, back then, we still had Asperger's, which kind of was a separate consideration. And now, both between the NIH has offered us other kinds of things that we should be looking at. and they're listed, all of which may relate in either cognitive and or developmental and or social kinds of setbacks for people. So it's not just autism spectrum. And I actually did a survey with people when I said IDD, and I think it was 80% said autism. None of them mentioned any of the others: cerebral palsy, Downs. I mean, and in technicalities, they are IDD, and they could be awarded benefits if they met certain criteria. My other thing is that I did thousands, and that's not even an exaggeration of, and watch me cringe, Social Security disability appeals cases where IDD is, that's where my real first exposure came to IDD. I am not a clinical specialist, and I'm more of a policy person, and I've used my knowledge now because I do forensics and criminal responsibility, which we'll talk a little bit about, because some of our folks who are on the spectrum and with other things do actually behave that in ways that they get in touch with the law. So that's kind of just an overview so that we're not always just talking about autism spectrum. There can be a lot of other things. So that's the first. And I'm technically disabled. So we're going to have Leslie clicking this. I hate doing this to her, but next slide, please. I've never done that. That's so much fun. These are things that we have taken from the AAIDD site, and there's a couple things here that I think are really critical. And the idea that the way I used to look at IDD was that it had to be something that happened really, really early in life. And there's some stretching now as far as from the clinical standpoint that it can originate before 22. The NIH standards talk about it being before 18. And then most of the time, what we've gotten used to, and I think most of you all, and you're all much more smart. You're smarter about this than I. But we get kids who are really young, who are having trouble, who cannot stay in their homes, who, as Senator Hunt last week in the judiciary hearing said, those little kids who we couldn't keep in the home become big kids that we can't keep in the home. Now, what do we do with them? So we're talking about, from your all standpoint, a lifelong issue. From my perspective, it is fairly truncated into what do we do with people that behave in a manner that bring them to the attention of the law or are such that they find it difficult to maintain them in the homes, in a home setting or a less restrictive alternative setting. A couple of other things that we look at is we look at, I think the three things is it's not just your IQ. An IQ is a score that is very valuable in certain things. For me as a clinician, somebody can have an IQ of 70 or they can have an IQ of 140, but each of them may have deficits, and they may have significant deficits based upon how much we spend time looking at the subtests. Pearson has been working very hard to provide us with statistics. That's the company that makes the WAIS 4 and soon to be the WAIS 5, to talk about how do we develop IQ scores upon what populations are we dealing with. And they now have these subclinical scores that help us look at specific populations in comparison to other people. We use a thing called the dementia rating scale for people with, with dementia. I mean, I was thinking about saying like Alzheimer's and things, but and when you do a comparison on that, using that score, for instance, we're scoring all of those people who are taking a dementia rating scale against all the other people who are demented. Well, we have a normal population, but compared to all the other people who have dementia, they may be high, functioning in the highest 10%. I think the 70-75 is misleading at times, because that probably won't lead to total a declaration of disability. I think that's important from my side, because when we're looking at somebody, say, who's competent to stand trial, who has an intellectual and developmental disability, who has an IQ between 70 and 75, we actually have scoring protocols now that we can actually assess that. And that does not necessarily mean they're not capable. The next little comment is that we have really moved into an area where scores are not as important as the impact of what is going on. As a forensic psychologist, and I'm doing this so that you get the perspective, because I'll have some fairly strong opinions. I don't care whether somebody's schizophrenic, has schizophrenia. I don't like saying somebody's schizophrenic. Somebody who has schizophrenia as a diagnosis or whatever. We look at the functional ability. And now in the forensic world, for those of you that have not been exposed to that a lot, diagnosis is necessary by statute, but not helpful often when we're doing these kind of evaluations. So I think that's really important. We can have an IQ score of 70 and the person may be able to do fine with their ADLs and everything else. We may have somebody who has a score of 81, but has other things going on that makes it impossible for them to put information together to make adequate decisions. And they are based upon not, in quotes, a psychiatric problem, but more of a combination of adaptive functioning and a whole bunch of things we'll talk about later. But just remember that thing. The idea now is, as we're trained, I loved it because diagnosis is just such a diversion, because if all of us on this thing, all of us were diagnosed as having anxiety disorder, I bet you anything, out of the 34 people here, we'll have about 15 different ways it's manifested itself based upon our basic personality, every place else we're living. So that's kind of the functional out of defining the criteria for the next slide. It brings up all the other kinds of things that we should be taking a look at. And I'm not going to read the slides, but I think these are things that you all know by dealing with the population. I am most interested in being able to take a look at each one of the levels. For instance, if we try to administer something like the WAIS, the Wechsler Adult Intelligence Scale, the problem is can the people actually take the WAIS, and is the measurement we're getting because they don't understand, they can't process, or because they actually lack the ability? That's the clinician's responsibility to know that. And how many of these kinds of things, whether it's any of these, are relevant to the issues at hand, such as independent living, gaining abilities, moving out of their homes, those kind of things. And so we have to link each one of these concepts, and this is what I try to do, is how do we measure interpersonal skills, ability to follow rules, and laws. And very often the victimization is not the kind of thing we think about people being victims of assault. The victimization is, and we all know this, and this is why I'm so interested, is where do folks with IDD issues end up if they act out as a result? And we're going to talk a couple minutes about the acting out. But we hear across the state, and I suspect all of you will be able to hear, I see some of the disability rights folks are here, they end up in jail. They end up being transported because they've misbehaved, they've acted out, they've scared someone. EMS may be called. What do we do with them? Well, we'd like to be able to put them someplace safe and have them be de-escalated and taken care of. But because they've done a behavior that scared somebody, they end up being sent to the local regional jail, or maybe put in front of a mental hygiene commissioner who then says we don't have any place to put them anyway. The bottom line when we talk about standardized tests, we have IQ, we have, all of you know this better than I probably, for who do the evaluations. We have that, we have achievement tests. And again, an achievement test, how can somebody read? Maybe they can read at a 11th grade level. The interesting thing is when we do reading recognition, we're going to get something that says, hey, they can do this at 11th grade level. When they do reading comprehension, they're at kindergarten level. Now, that sounds like an oxymoron, but people can read, but they may not understand. And we're always faced with that process, whether it's under the guidelines from Social Security for disability, or whether it's from other kind of things. Next slide. I know I'm going really quickly on this, but we got an hour. These are the other kind of things that why we're all here. When I fell into the ECHO group, I'm a stranger in a strange land. I'm willing to admit that. I've become less of a stranger. I'm attending 2 more seminars on autism in the next 2 months as they integrate with the criminal justice system. But we have problems. We have a society that says, let's take care of people, but we have a society that says, how are we going to do it? Because we don't have a lot of money. In West Virginia, it's particularly difficult because our population density issues cause us problems. Where would we put a step-down facility? We can't put one in every single community in the state. It would be lovely if we had Starlight having facilities in 15, 20, 30 places where we could put in 100 people. We don't have good numbers yet, and I don't have the numbers. This may be something that you all can provide me, is how many people do we estimate have actually an IDD issue in their lives? And then the next step for me that is interesting, and which I'd like to hear feedback, is what percentage of those people end up going from being identified as IDD, being in training programs, being in alternate places, who actually have interactions with the adjudicatory system. And that kind of number is something we hope to get once our bill's renewed this year. The other things that we've talked about is just language, the ability for people to understand what we're saying. I always laugh when I start. As you can see, I can't speak very quickly. And I'm from Boston originally. Now, I do say things that sound, when I go to Boston, they think I have a disability because I say the S word with 2 syllables, and I don't say the things that they say. And my cultural changes are there, and we sometimes misunderstand each other. The interesting thing, and Leslie and I, when we're going over the slides, limitations often coexist with strengths in a person. And I like to start the other way. Strengths often coexist with the limitations in a person. We don't generally get folks put to my world unless there's something going wrong. And we focus on pathology, we focus on deficits, we focus on the things that may get them benefits or may get them in a protected setting or anything else. But we forget some of the unbelievable imagination kind of things. If there's somebody on here in Starlight, they're probably familiar with the Star Wars advocate that they used to have or may still have in their place. This person can name every character, every location, every other thing, but could not last one day in the community on his own. So we take a look at what can we do? And this is what hopefully ECHO is going to be doing for the global population, and hopefully we'll be able to stay in touch with all of you. And as many of you would like to have input, please feel free. What do we do to divert them from the criminal justice system? What alternatives can we really come up with? And how can we have messages delivered to the legislature? We have been received very well on this initial study, the first year, and we're waiting now to see whether we're going to be re-upped, but we're really hoping they're going to listen to us. Next slide. I love saying that. That's just so much fun. This is just going over the kind of things. When you look at the information from the National Institutes of Health, they make it very clear that, and I think the present IDDs usually present at birth uniquely affect trajectory of individuals' development intellectually, emotionally, and many of the conditions affect multiple body parts and systems, and they go through the nervous system, metabolism, sensory system, degenerative stuff. But what it comes down to is that we have a wide array of symptoms, and we're going to talk about how this gets confused. But first, the conditions of development. We now know that there is onset later. I'm not sure that, and I haven't looked at the laws, we may identify somebody at the age of 18 or 22, but I'm fairly sure we have to show that that pattern has been existing for quite a while. I just see somebody putting something about the new draft manual of CMS. God bless CMS for telling us how we're supposed to look at the world every 15 years. But we're looking at the day-to-day functioning. I have some friends who have folks who are experiencing DD, and they're the most lovable human beings until they're 18 years old, or until for males until puberty hits, and then something strange occurs. We have group data. This is a big deal. And then we have to take a look at, on the standardized tests, what's going on. And the criteria clearly is substantially below that expected for the child's age, intelligence, and education. But we have to add in, and this is really critical for West Virginia, the differences across all of our different communities, the value that's placed on education, the access to care. I was on the well, I can't even remember, APS advisory board, professional advisory board, and we had a professional and a consumer groups. And the fascination I had is that there were so many differences in access to care, transportation. One of the things that we came up with, this is years ago, and this is appropriate to hear, we asked what the professional group asked the consumer group, what do you think we needed? And the two things they said, and I'm not meaning to be offensive to any of the mental health centers, but I usually within an hour can offend at least 5 people out of 30. We asked them what they wanted. They said, we'd like to have daytime hours so that we don't have to leave our jobs or take our kids out of school. And we'd like to have transportation. And when the committees were disbanded, neither of those changes were put into place, which impact day-to-day functioning, access to care. What is the level of education to the parents? How do they understand what we're telling them for rehab and all that kind of stuff? So these are all issues that I think are every single day for us a real critical and often moving target. Next slide, please. And this is kind of goes back to the other conditions, but I think that when we're dealing, I suspect there are, from my naive standpoint, there are lots and lots of people in the community that have components of or fully blown IDD patterns that we never have trouble, we never see. Somehow they have the familial or the community or whoever that are taking care of them, but when do we get them? And take a look at each one of these. With the autism spectrum, there are a lot of folks who have autism spectrum issues who never come to our attention. They're docile as they develop. They don't develop the hypersensitivity to certain kinds of things. They find a way, and their family finds a way, and they do well. Same with Down. Same with fetal alcohol in some cases, which I think is more difficult than a lot of things. But each one of these, this is really funny. I usually talk with my hands, so I'm trying not to here. Each one of these on here, under autism spectrum, the ADD, every one of them causes some kind of discomfort in the people around them. And these co-occurring disorders, depression and anxiety, are primarily, usually, the mental health realm. They say psychiatry, I say psychiatry, psychology, social work. For those of us that work in clinical mental health settings, ADD is specific, but how do you deal with a ADD child? I have a niece, and she'll kill me if she knows I'm saying this, who's now a second grade teacher, who's wonderful and bright and lovely and tremendous. But boy, she wasn't that way when she's 3, 4, and 5 years old. We wish we had a set of nets around the house sometimes, because she was ADHD and she made it through school. She's doing wonderfully, but she came to the attention of teachers because she couldn't sit still. She was mouthy, which she still is. I love her to death, but she's sometimes difficult. And because she's difficult, as parents get older or the community changes, they come to the attention of someone with impulse control issues, as well as the affective and behavioral changes associated with depression and anxiety. We have overlap, we have co-occurring, but for me, watching what has happened in my 50 years of doing this, when autism was like a paragraph in our diagnostic world back then, and you never wanted to say that, it was almost as bad as using some of the more severe mental illness things. We treat behaviors. And autism spectrum disorder, yes, we know, for instance, that there are changes in the brain or changes in development and changes in this person's internal stuff, the biological side. But we have in the past often diagnosed someone, and if some of you may not be old enough to have known this, but when somebody would come in with autism in the olden days, I'm talking the 70s and 80s, they would not ever be called autistic. That was terrible. They'd have ADD, they'd have depression, they'd have anxiety, and guess what they got treated for? They got treated for each one of those clinical entities, not for the collection of problems that was resulting in them being able to be defined as being on the spectrum. The hypersensitivity, all the things that we now know. And if they were sad, maybe if they were higher functioning, maybe up in the Asperger's level, they would be really sad. And so they would give an antidepressant. but there were a lot of other issues that we had to deal with other than this. And so we're looking at these entities, the ones that I mentioned earlier, and the behaviors that are going with them. And we'll talk about the overlap between the two, but these are the kinds of things that we see. And, if you have somebody on the spectrum who is has a lot of the ADHD kind of things, what gets treated? The ASD part gets pushed aside and everybody goes targeting that. And when you see the clinical notes, they're focusing on that behavior. And as a forensics person who does damages, who's worked with Barbersville, I've worked a lot with ResCare, with REM. As soon as they can pick a focus that they might medicate, that becomes the focus. And although it might be like having a personality disorder in an adult, we start treating the symptoms and we forget how complex the situation has to be. Next, please. This is the diagnostic overshadowing. It can be either way. We who look at the functional abilities, people tend to want to kind of discount it being a psychiatric disorder, and I hate that term, but we have to use it. That when you see this thing, we can minimize the idea that there may be something else going on by saying, oh, it's just their intellectual disorder. Oh, it's just that they have a developmental disability. Oh, and that's one side. And then the other side is, oh, we got to come up with a diagnosis. So we bring them to the mental health center, we bring them to someplace, and that's another issue in itself. And we go through the battle between, not even the battle, the failure to connect everybody with the individual's unique set of problems and try to work together. And this is the part that's so difficult. Trying to work together from all different perspectives, whether it's housing, education, psych, occupational therapy, physical therapy, ABA. What I've learned in the past year with our committee is we got a lot of great stuff going on and nobody knows about what every community is doing. And we don't have enough of the great stuff going on because we're a huge state with a low population base. The cloak of competence is interesting. I have been with people who are on the spectrum somewhere, and I would not have known it unless we moved them out of their comfort zone. I'm going to take 2 seconds on what I call figure one of my funniest stories. I had an individual who was facing an enormous amount of problems with the IRS because he was made, and I'm going to try, I'm dummying up this a little bit, so it's no confidentiality issue, but he was made the executor of the estate, and he never filed any papers. He had the material and he never got to do it, and he was very odd, and I won't go into the oddities of his behavior, but he was really odd. But he had 141 IQ, so he was a Asperger's-y kind of person, no eye contact, et cetera, et cetera, et cetera, all the social deficits. And I was retained by an attorney saying and excuse me for using the politically incorrect word, I was told that they were thinking he had to be psychiatrically disturbed. And they got really upset with me. I said, I don't think so. This is very strange. And my education that night, if any of you remember Boston Legal, I'm not going to ask for a hand raising, but there was a guy called Hans, and he then became the medical examiner, I think, on CSI or something. But he was definitely on the spectrum, and always very neat. But his hands, he had oddities of his movement. And I'm sitting in bed, getting ready to write up my report, and my wife goes, "What's going on?" I go, oh my God, that's him." And I said, that's what he is. And they mentioned him being on the spectrum on Boston Legal, and it opened up my whole world. And long story short, when we wrote the report up and we explained that he was incapable of doing these kinds of things based upon a true disability, but he wasn't psychiatrically disturbed. He was developmentally disturbed forever. They stopped the action in the IRS, and they let him redo the case, and they gave him most of the money back. I thought that was kind of a cool outcome by looking at 141 IQ. never would have been developed. He went to school. He had a job that he was in for 30-something years. Very good at it. But boy, when they moved his cubicle where he was working to another place, we had about 3 months of disruptive behavior. So this is kind of the things that we have, either too much of a look at its mental health or too much of a look that it isn't mental health. And then what do we do? Because we're not really good at social parts of the programs, and there are overlaps, and we have to have both, but we have to be better, I think, at the integration and not letting one be so dominant than the others. Next slide, please. Looking quickly up top. This is a little bit more on the overshadowing, and I just think I covered that. And I underline clinicians' perceptions. And I'm going to ask those of you that would like to just think about this. How many of you have ever dealt with people with seizure disorders? This is a parallel. And if you've dealt with people with seizure disorders, they go to the neurologist and they'll come out. Some of them come out with an increase in their medicine. Some of them come out with a decrease. Some of them come out with no change. And when you listen to what was said in the neurologist visit, this is the clinician's perspective, and this is based upon tolerance of certain kinds of behaviors, your experience with the IDD spectrum, and I'm going to say the IDD spectrum, all of the different IDD things. When somebody comes in to a neurologist and they say, well, how was your month? It's really good. Any problems? Nope. No escalation, no extra problems with my seizures at all. And then the next person goes, oh, it was a horrible month. We had more seizures. If you go in and you actually check how many seizures, the increase or decrease, it's based upon the subjective presentation of the patient and not objective data heard by the physician. That goes with pain, that goes with disorientation, that goes with acting out. When we have IDD kids that are acting out in the home, some families have more tolerance. So severity is really a subjective kind of thing, unless we've got them in an institution where we can watch and check these kind of things out. So how severe are they? We have to be really careful on how our biases or the biases of the care providers are distorting what we're really seeing. We have to talk about the specific disorder. And for me, that becomes really critical on what are the full capacities of this individual? Are we dealing with just a developmental disability or whatever? Do we have brain damage? Do we have a closed head injury? Have we had a toxic substance? Has it been fetal alcohol? All of those things lead into how we address, in quotes, severity or the generalization of the difficulties and what we can actually expect without limiting and having the Pygmalion effect that we're going to start thinking, oh, they can, if they've got this is they're only going to get to this level. But we have to be honest about not trying to get people into a place where they can't do what's being asked. That's why I like ABA, because it's so regimented and you can make the progression based upon achievement, but not assume because they're very charming when you're sitting at the table until they don't get their gravy passed on them, they have a hissy fit. And there's ways to be able to start looking and how the disorder should be treated. If anyone comes up with that, you're going to win the Nobel Prize, or they won't have to meet anymore. But I think that the bottom line, which still comes from the autism group, the IDD group, the severity of symptoms prompts more of a medical or a psychiatric intervention. And the idea that we underdiagnose the mental health conditions, often leading to mistreatment or non-treatment of these conditions, it's much more complicated than that. I mean, I've sat for 50 years watching the evolution, and it's the lack of coordination of care and mutual respect among the treating disciplines that I think is as critical. You know, we run to the psychiatry people or to the physicians, please give us a medicine that decreases agitation. So then we give them one that decreases agitation, but increases somnolence or focus. And so the respect and giving us a way of better assessing is going to be critical to figuring out what to do, and then having the community resources. Next. These are statistics that are not mine. I think they're fascinating. And when we talk about documented factors associated with institutionalization, one of the things that the DAB or the study group found is that every single one of our groups has problems. Whether it's institutionalization at a psychiatric facility, in a jail, or in a non-productive home, all of these chronic problems give us a lot of trouble. And so what we have to try to do is, in the lack of access planning and ongoing training, I am hoping, Leslie, this is to ego, that you and I and have a lot of nice, in our group, have a nice, and anybody here that would want to, would have a lot of nice conversations over the next year when 232 becomes 632, and we can talk about these issues. How do we gather the information? What we want is we want a statewide database that allows us to have accurate ideas about what's happening and what the limitations are and what we've tried. I've read more IEP. How many of you have read IPEs or treatment plans that have these goals and they keep saying the same thing for 20 years? And or they don't identify really what we can do. So this is really critical. And I have one friend who has a son who has multiple things, but one of his things is on the spectrum. He would be driving down the interstate in the back of his father's car and see something shiny on the side of the road, generally silver, could be anything from a bottle cap to a necklace. And he would get so agitated that they'd have to stop the car and he'd have to go back a half a mile and pick that thing up because he could not get his focus off. And what do we do? And God bless it. And if he ever sees this, the father knows who he is. This man has supported his child in a way that I can't believe. The kid shakes my hand now, eye to eye contact, has some affect and makes a joke. So I never want to think that we can't help people go beyond where they are, but I don't, and I'm going to use a stupid example. I was a competitive swimmer and I always wanted to be really good, but I couldn't swim butterfly. And no matter how long my coaches put me in the water, I could never swim butterfly, but they always told me I could. And I never became really, really good until they recognized that I was a really good freestyler and I sucked at butterfly. I couldn't do it. And I wasn't very good at butterfly, and I mean, breast and back, but I was a really good freestyler. And my life began to develop as a swimmer. It's a long, long time ago, believe it or not. If you see me, you'll know that that's a miracle, but long time ago. And we have to know what they're good at, not comparing them to everybody else. For each of us, how many of us are in positions where we never thought we would be in because we weren't good at some things and people failed to recognize what we were good at? And how do we share this data? How do we encourage and how do we not feel depressed? One of the things I would like to be getting some input from later, and I'll give you my contact information later, is what do we do? What do we do in the community? How do we find a way to share the information and now develop a system of providers? We've had the autism group down at Marshall that was so well known. We have some ABA and pay people. I've tried to mainstream some kids, but that's not always worked for one way or the other. We don't have as many special needs teachers out there anymore. There's a lot of things that are deficits to get in our way. And the last thing, and this is a place where because I've been seeing some of the chats coming up, I'm not now. I used to be really good at the Social Security parts of the IDD stuff, but the bias and the idea of what are people's rights and what do we have responsibility for and how can we best impact it? And how do we bring the families in so they don't feel overwhelmed? And that's one of my biggest concerns, is that we ask families to try to do things that we've been trained to do. And it scares the hell out of them and they never get used to it, because if something doesn't go well, they panic and they don't know how to not get upset, which then overstims the person in the environment. And we get a call to the police. Next slide. These are the kind of things we've talked about this already. And we talk about etiology, and I think that's important for structuring the kinds of programs we can do. If you have a FAS kid, a fetal alcohol kid, and they're in trouble in school, we're in trouble because there's not a lot we're going to be able to do that's sustainable because that damage is done. It's just like having somebody that's had a really bad frontal lobe injury, TBI, who has no impulse control, their executive functionings have been done. We have to know what, and the medications may or may not alleviate aggression if certain parts of the brain, and we keep struggling, and then they end up either institutionalized in a mental institution. I hate that word, because we don't have the step down stuff that's safe. This is really difficult. And I put the last line in here on my own. I love this. The three first ones, I suspect everybody knows. If you're going to be working with people to try to advocate, but the last one is the hardest one, and that's honesty of the system of what they're doing, of the people that are taking care of what they're doing. And I think really, 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 the honesty of the people that are dealing with their family members. I have a brother who was a drug addict. I have not talked to him in several years, but our family did not want to accept that he was never going to be what we thought he was going to be. We have 5 high performers in our family, and we have one who could have been, he was a genius. His genius was he was a contractor. He built barns. He had a patent on a barn door for any of you that are horsey people. And then one day he built a barn and they put non-galvanized nails into it, and it rusted away, and all of his assets went. And from that day on, he was not very functional. And we had to be honest. And that's the hardest thing in the world, whether it's mental health issues. It can be across the board. And I think Jason's had some really good points. We use for discipline what we were usually raised with, or our attitude towards healthcare, or now the worst ones are Dr. Google. If you have families that are given a care plan, we have to get an honest report from them about how disruptive the kid is. Do they want to get rid of the kid from the home? That's going to be a different thing than them having the cultural thing of how can we possibly ever get rid of our child. Then they're angry that they're not getting the community support they want. On the other hand, if we can't take them out of the house, we're leaving them unprotected. And sometimes the advocates can't win. And those of us that are trying to help sometimes aren't even aware of what the right thing is. And it varies by family, it varies by community, it varies by condition. So next slide. Now we go to the case presentation. Ooh, any questions before we go? I've been seeing the comments. I wish I could have responded to all of them. I'm humbled by the fact that I may not know as much as you all do, but I've been doing this a long time. And in most cases, I'm a do-gooder. I was a seizure specialist as an intern. That was one of my areas. And we dealt with idiopathic seizure disorders that we couldn't figure out why. And this is, I think, a part for me that is more educative. We thought because they had seizures, there was just something the matter, and we called them epileptics. I hate that. But we have people with seizure disorders that would never give it a try. And when I came down here and I did my internship, we tried to work with people to give them a chance to do stuff where we weren't biased about the fact that they couldn't. There was a woman named Jeannie that had terrible things. She was one of the first people in the country to get a Johns Hopkins to get an implant. She wrote to me the day that she returned from Johns Hopkins with her implants. And she said, "My God, I have gone through one full day of my life without having a seizure. Now I don't have to struggle so much to do what everybody else seems to do, just like it's easy." And she made wonderful strides. We had one guy that would sit there and he'd be looking at us, and all of a sudden he'd get up and he'd run and he'd go through a plate glass window. Well, could he help himself? No. All the stuff that we did, his sensory stuff, he just didn't picture things in front of him. So we've got a lot of things that we look at now in the 232, now to be 632 study group, that says, what can we do? And what kind, and this is going to be my last political part, because I know we've got about 11 minutes left. We have to do this as unified voices, not just from our each one of our little tubes, as I call them. We've got to be able to say, this is a universal problem, not just for us with the IDD kids, but the IDD kids that become IDD adults, for the families that have other children. I had one case where I had to take one of the children out of the home. It was horrible. It's a long story, but the rest, they had no capability of keeping the family intact if this child stayed there. They had 4 other kids, and this was the youngest. So there's a lot of the things that break my heart. There's other things that anger me because of policy. And there's other things that really frustrate me because the luck that I have as a forensic expert is, guess what, folks? I get to see every single piece of paper on a person who is in a litigation thing, whether it's against Barbersville or against ResCare or against DHHR. I get to read all this stuff. And the sadness is that some people have not read what's gone on. We have one person, one of the Starlight people, I think there was at 11 treatment facilities. And I read every page. And they're doing a great job. This kid's lived on his own, but they should have read what was going on, because every single place did the exact same thing over again, thinking they were going to, because they were smart, they were going to get a different result. So, case presentation. When I read this, it scared me to death. Do I have to read this? This is the grown-up IDD kids. So, Leslie, how much you want to do this? This is your part that we hadn't rehearsed yet.
Sure. Well, we can go through, definitely hit the highlights, and while everyone's going through it, and then we have our questions and discussions. So again, as we go through here, chat's been wonderful. Keep it up if you prefer chat, and then raise your hand or let us know if you want to comment. But this is the get down and into the discussion. So I'll just go over and highlight a few things if that's okay, Dr. Clayman.
You go for it.
Right. So we have 2 younger adult males who are twins, pretty significant in stature, 6'2" in general. This is average between the two, 240 pounds. Both live with their mother. Father is not in the home. An aunt and an uncle live a couple of miles away. One of the twins has been diagnosed with an intellectual disability. We're going to leave it unknown for right now, just to add some spice to the discussion. The other twin has not been diagnosed with an intellectual developmental disability. Both are showing aggression more and more as they age. And just to give you a little bit more, Luke, the one who has been diagnosed with an intellectual or developmental disability, has caused some significant damage to the home where he lives with his mom, and has also started to show some aggression interpersonally with others. His brother is aggressive to others, but is not damaging property. A lot of it's contained within the home, hasn't gone into the community just yet. So we would throw in some genetics and some shared environment and a little bit of both. Yes, both were evaluated. Juliana, great question. So just like Juliana started, what questions would you ask? We've included some here, but do not let that limit you. So what are the differences? What are the similarities based on what Dr. Clayman has mentioned? What should we watch out for and not fall into a pit of bias? Let's put it out there generally right now. Really great question. So, Mina, what do they want? What's the goal here for both the twins and perhaps family too? That's a very good, kind of gets back to the strength training approach or strength approach that Dr. Clayman mentioned.
And one of the things that here's our first bias. They both come from the same family. So why the heck are they different? That's the first one. I'm the oldest of 6. Boy, you wouldn't know it well, you would, because there was some similarities, but real differences. And the one that's the least productive is the one that probably has the biggest heart and gets made fun of by us a lot of the time, because we call him our little old grandmother, and it's a guy. Sorry about the somewhat sexist way of saying that, but he just worries. So there's our first, is the considerations. We don't know what neonatal issue was. How were the pregnancies with the mother on both of those? Has something changed there? Were there any birth-related deficits, like at birth, where there may have been a bad birth where there was some damage done to the brain, et cetera, hypoxia, what with the blood. And you go and you look at all these things, and by the time we get them in for evaluations, nobody really wants to go back and try to get this unless there's litigation. That's what I've learned. Nobody really can tell you what their APGAR was, or whether they met developmental milestones, because a lot of times people can be motor coordinated and fake it. We used to talk about people with low cognitive development, and I'm talking the 60s to 70s, who are absolutely delightful, but they would make up a life. You didn't know that because they did not want to be identified as being, and I'm going to use the old term MR. They didn't want, they presented a completely different view of themselves until put into a situation where the evaluation revealed things. And somebody wrote here, and I want to give Jillian, I think it was Jillian that said that the testing is terrible. I hate to agree with you. When we have the Vineland or we have the ABAS, whatever, they're
Not
checklists.
not only is it terrible, but I've sent 3 consumers in the last year to go get full psychologicals, and they literally just regurgitated the QPro assessment back to us. They
These,
didn't start over. They did not break it down to where they truly are. They regurgitated the QPro assessment right back to us.
Jillian, this, unfortunately, that's where everything is. If you take a look at EMR now, and please, all of you who have been in touch with the medical health system, get a copy of the medical record, because what they often do is the intake information taken on January 1 is the exact same information that's in the chart 3 years later as their problems. And what that does is that biases care. It looks like they've not been compliant. They haven't been taking care of themselves. But I hear your frustration, but because there's such a demand for these kind of things, we're now in a position on one of our other at-risk populations that we have to do a risk assessment. So hopefully they're going to change the law now. There's a presumption of non-competence in anybody 14 years and younger in the system. We don't have the people to do them, so they do the least possible. The problem for me is if anybody has ever run into my reports, I just finished a 32-page report where the person that did it on the other side of the litigation did an 8-page report, which was unsatisfactory, by the way. So your frustration is there. What do? You have to, who do you turn to? Who in the agency that you're working with? Where are the referral bases?
This was more than one psychologist. This was, I'm sure they got fully paid to do it the way they should have done it. But if you read the report, literally it is word for word the QPro assessment. And we already had a QPro assessment. We know what that says. So why can't you, as a psychologist, break it down more so that we know where this member's truly having issues?
Well, that would be the first recommendation coming out of this meeting, and we will take back to the DAB part, is getting an accurate workup. That's the problem is, for instance, on all of the the Vineland and the AB, that's my learning disability. They're checklists, and they're based upon the subjective reports of people in and around the environment, or maybe the short-term stuff that you see in a workup. But we don't know what bias. We don't know how accurate that is, and we don't have a coordination of people that may be going into the home or going into the school system. And somebody wrote that they haven't seen people going in the home. We don't have anybody out there. Nobody's going to pay for it. And part of this too, Jillian, is the psychologists who are doing this sometimes are doing it given CMS and or other agency restrictions on their fees. And to do it right is a really difficult thing to do in 3 to 4 hours. The one case that I did where we got the kid on the IDD waiver list, it took me about 27 or 28 hours.
Well, and I have kids that are on waiver now because of the autism and things like that, that should age out because they've gotten the support. So by 5, 6, 7, 8, they are good to go. And for whatever reason, that's not happening.
Well, I think we're dealing with policy, and we're dealing with deeply ingrained views of things. And I think groups like this collecting these data are our only chance to present. And I will work with Leslie through ECHO to try to put these as part of our next level of responses. The more specific we can get, and I see Randy's here, the whole bunch of people I know the names now. We need these kind of real life situations that we can turn into stories that are understandable, like this, because I know I got to see there was a note on the bottom of one of these slides that kind of the rest of the story, as Paul Harvey used to say. They're not aware. They're not aware that IDD is not a specified thing like strep throat.
Correct. But you have, and it's happening all the way around. And the whole reason we sent these members to go get new psychologicals is because we were trying to find out if they are starting to have dementia or if it's their IDD diagnosis. That's the whole reason we sent them.
I'm writing this down.
I will never send another consumer for first full psychological again. I will send them to neuro because at least then maybe somebody will do something different.
Well, I think the thing that you may also be talking about is general psychologists may not have the skills a neuropsychologist who has been trained in some pediatric or in developmental disabilities will have a better way of measuring and taking a look at things. Just so you know that. But feel free after and I'll give my contact information at the end. Feel free to write to me and talk to me about these. Let me know about these things because I'd like to bring them up to our group as well.
Okay, great.
The assessments we would conduct, who knows? Ones that are addressing the issues. We still have to have a good medical workup on the aggression and on the acting out. There's a rule out. The model is biopsychosocial. And I'm a diabetic. I have to take care of the biological sides of me that are impacted by I have to take care of the biological sides that are impacted by the psychological sides because I'm a sugar addict that are also impacted by the social world of how much stress I'm under and how my wife is treating me that particular day and whether I need soothing. And I'm not being silly. If I don't deal with all three, I can take all the medicine in the world. I'm still diabetic, but I still have trouble. So we have to be coordinated. We have another group that meets on discharge from the prison system. We've never talked to each other before. Never. And we're talking to each other. We don't want to make a move now unless we have this multidiscipline group coming in. So if you have troubles with getting the right kind of stuff, while this does not fall under the forensic coordinator's job, but we have one of the smartest people I've ever met. Colleen Lillard is our clinical forensic director for the state, forensic director. I, as a forensic psychologist, get to see the work that other people do, and I feel like a creepy face because I'm so critical. So you've raised an important position, and please take the time at the end of this to write to me and give me what your concerns are, and we'll try to put that into our pipe and light it up and smoke it while we're working this year when we get redone. The treatment options, it's going to be different. I mean, that's a wide open question. How are the mother and father getting along? How many of you have dealt with families where the father's got no buy-in whatsoever? He's busy. He doesn't want to be bothered. He doesn't want to come home to the house. And the wife's saying, you know what? Joey just beat the crap out of his sister. He's sitting in his room now rocking. And the father says, I've had too hard a day at work. Or the mother doesn't want to be nasty to the child by implementing what we know in long-term by being consistent and stable. We're going to get reactions to bring them to the highest level of functioning for that person, given their abilities, and not having fantasies that they're going to run for office for the presidency. And that's, some people come in expecting the providers, and you all know this, to make things better to the point that this person has no problems left over. And I got a ripped quad tendon that I did about 8 or 9 years ago. I've done everything right, and I still can't do the things that I used to do on that leg, and I have to accept that and stop trying to push myself. It's stupid. Or being old and still working, lots of hours. So in this case, I think there was an add-on to this. Wasn't there, Leslie, a little bit of more information about the situation?
I think
that was in a note from from the semi.
Right, that was
but,
in the chat.
but
We
here,
received that from the chat.
and I think this is the stuff we've just kind of been hinting at. Where does it come from? And remember, medical and psychiatric the same, and neurologists and psychologists and all of us should be getting along and working together with our specific areas and not assuming that we all know everything. I know what I know. I know what I don't know. The environmental factors. What if you've moved and you're now living next to a railroad track and you've been in a really quiet rural setting? What's that going to do? I mean, just that simple thing. What happens if you send a child to a middle school who's always been in a small 35 student, small school in a rural area and now has 75 or 80 people they have to deal with? What do you think is going to happen when they come home? This last thing is really important. This is the planned or reactive aggression. What happens standardly now, not standardly, but we have a child who's IDD. Something happens in the environment, excuse me, mother may turn the television off, it may be a sound, it may be lights or whatever. The person, because they have disinhibition, loses control, the mother comes at him, the kid smacks the mother in the face, breaks her nose, this is a case. The mother tries to stop him, she hits him, he hits her again, and then he goes running through the house, destroying things, screaming, I hate this, I did, and sounding like he knows what he's doing. They call the cops. The cops come, and guess what he does? He bashes the cop's head. Now we've got assault from the mom, destruction of property, and assault on a police officer. Where are they going to take that person based on those behaviors? Those behaviors are criminal. But are they reactive to something internal, or are they planned? Are they just something that happens because this is the way the kid is? Do we have to look at the environment, or did the kid plan to do that? And there may be a mix. Sometimes some of my folks who are on the Asperger's end of the things would have all these odd things, but then say, but you know, I knew a mom came home. If I'd peed on the rug and the carpet, she wouldn't get me for everything else. That's a quote. And so there was some planning in there. It's never all or nothing, in my view. Behavior mod, it's how do we identify the triggers? How consistent are they? What is something new? What happens when it doesn't work? How do we get people to buy into the responsibility that the family may have, or the school may have, or the friends may have to be participants in this behavior problem? When we first started having behavior therapy in the 60s and 70s, that should age me. We knew that when grandma came to visit on Sunday, all the efforts that we put in between Monday and Sunday were going to go in the can, because grandma would give them the candy whenever they wanted the candy. And we had to have everybody on board, and grandma would say, oh, I can't do that to Johnny. He's my grandbaby. That innocent, that non-malignant, but that difficult. The communicative stuff, assuming that people understand our words. I have to warn people when I'm interviewing them that I use doctor words and big words because I like them. And if they don't understand me, they should tell me to quit it and stop doing that. But we have to do that, and it has to be done. I'm going to go back to Jillian's thing. We have to have better ways of going in and looking at what's going on, and not just filling out forms to fill out forms. And that's what I think a lot of the things that happen under CMS and everything else, people just fill out the forms. Did they ever read them? Did they ever go back and look at the IPEs? I'm sorry, the IPEs is my stuff. The IEPs. Do they set reasonable goals? They break them down into these little fractional behaviors, but what happens? Is there honesty there? Because we're supposed to be making progress. Well, progress sometimes is not as easy to measure as we think it is. The pharmacological treatment. I've been doing this a long time, and there are people that do very, very well in modifying some of the dysfunctionality in their lives by taking their meds and taking them regularly. And there's some people that, like people who were on dialysis, who couldn't drink water or eat tomatoes, and between visits would do so much we had to keep them on the machine to the point that it was dangerous to their health. They had to take responsibility for that and not lie to us. We're going back to the honesty thing. As an forensic person, I think one of the benefits for me over the past 30 years, 35 years, this is really kind of crazy. I don't trust anybody when they come in telling me this stuff. That's part of being a forensics person. If somebody says I'm depressed, I don't say, oh, tell me more about that with warmth, empathy, and positive regard. I say, show me, give me evidence so I can measure it and I can make a decision based upon real data. not the stuff that we have. So this is, I know we've covered a lot, and I've not gone over every slide in detail, but this is complicated. The fact that Leslie is committed to doing these sessions and maybe getting more and more micro after the first, what, 4, 5 sessions? And, if anybody would put up with me again for another hour when we get more micro, I'd be more than willing to come back and do more case studies and try to figure out from our committee standpoint, what can we do? And this is the last one. We look at all of this. Do you know it takes people? The 4 things we realized is we need more step-down facilities that are safe and humane, not bricks and mortar. And I'm talking bricks and mortar literally, like with just cinder block. But we have to have step-down facilities. We have to be able to put a forensic home, for instance, in Park and in Huntington. That's going to scare the hell out of people. And when we say we have IDD or we have all these other things, it scares people. We're not going to have to take care of folks if we put them in the right facilities. We need trained professionals. We can't be getting kids that are coming out of high school at 19 years old and getting a job with, let's say CPS, who have to live in their own communities and take care of acting out kids and determining whether there's parental neglect. I mean, we have to pay some more money. We have to have data, good data. And we have to have open, legitimate sharing across institutions. That's across all of you that are have special interests and across departments. DHHR has to talk to DCR. DCR has to talk to education. If we don't do that, we can't do anything. And the last part is we need money. And we have to show that if any of you and I ask for money, we have to show that there's a return on investment and it's not going to be wasted and squandered. And I know it's a little bit off the topic of just measuring IDD, Leslie. I hope I didn't go too far askance, but I just think this is a wonderful place for us to be, that we're actually now talking. And just think, in the balcony of the legislature, that it's not just people that are worried about Down or one of the syndromes, because that gets people off on a track, but we all go together. We all go together and say, let's have our day down there at the legislature, when all of us as a group speak the same language of what's needed. And I'm stupid enough, I think, at times, to believe that numbers will count. And if there's enough of us making not whiny noise, but addressing these things in a rational manner, we may actually get some people to listen to us. We do have some advocates, by the way, in the House and the Senate, both. Senator Deeds is real interested, Senator Kelly, Delegate Kelly. And I've had several other people come up since we've been down there. So my contact, because I didn't put on the slide, is DAC, like David Allen Clayman, DAC at Clayman Associates, ClaymanAssociates.com. That's my business address. I have not yet put up a new one that would just be for these kind of, for the 632 types of activities. Is there any way to save the messages?
Yes. So in the transcript, we'll have the chat, we'll have all of this. And just as a review, these are being saved on a website. We'll send the link to in the summary email that I mentioned in the chat. So we'll have some supplemental materials. We'll have the link to the recording if you want to share, if you want to review again. And we'll also include, Dr. Clayman, the comments transcript.
And Emily wrote about something that I just want to give it. Once adjudication is complete, program coordinator, blah, 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 and all this kind of stuff. We're trying to exhibit to the legislature now. We have a cooperative arrangement between the forensics people at Sharp and the people at the regional jails and the prisons. So when people come out of the Sharp and have been brought back to competence and all that, they're not sent back to the jail system and immediately have medication changed. We are actually communicating, which is decreased dramatically. I don't have numbers yet. The types of problems we're having with the people that are within those two systems, moving back and forth. So what we have to figure out is, in the strategic intercept model that we're using to define what we're doing here, the big deal is us being able to show that we're actually getting reactions and we are actually talking to each other. And I'm not very Pollyannish. It may sound like it today. I'm a real hardcore person. I don't like when there's no data. I don't like these other things. I think all of you, if we can work to show and explain and have people understand that IDD is just not a singular construct. It is a spectrum it's a wide-ranging thing, and in each one of those wide-ranging things are problems. Senator Hunt passionately talked about the fact that his son grew up. This is open. It was on the Senate Judiciary thing. That's what we have to deal with. We have to deal with kids, which are the more tragic things. But then the more problematic is, what do we do when they're not cute kids anymore? So, any more questions before we bolt? I know we're 15 minutes over, but all these comments are great. The burnout, behavioral respite.
And what we'll do, we'll share it with you, Dr. Clayman, so that you can take it to the work group, the policy group.
Right. Kelly King, Lord only knows. You want to help, and this is just really tough.
It is. We're living it. We're living it. Our son has a lot of obsessive behaviors, hasn't left the house in probably 4 years. Aggressive self-injury. Yeah, we're living this. And I work in the systems, and I'm a behavior specialist, and all the things we've thrown at him and nothing's sticking. And you'll hear him in the background, even today, you know, he's especially distressed. So I'm not alone. I know numbers of others who are in similar situations, and I'm seriously concerned about numbers of individuals on the spectrum who are coming up, and you know, the co-occurring ID and potential to overwhelm the system that's already poorly servicing them. So serious concerns. Thanks for your work.
I said this, Senator Trump, thanks for the honor of being there, given the responsibility of trying to do something. This is my last hurrah, kids. If this doesn't work, I'm giving up. I'm leaving a legacy. I'm gonna have to base it on what I've done before. So.
Well, I have people messaging me, you know, placement for any of these individuals is exceptionally difficult. Agencies can't get staff. Agencies certainly cannot afford to pay the kind of staff that a lot of our demographic really needs. It's leading to burnt out staff, burnt out professionals who are working with their hearts because that's all that's left. And burnt out families who either have no choice but to deal with their adult child, or place them hours and hours away if there's any placement at all. Which then puts that loved one hours and hours away from any of their natural supports. And that's providing somebody steps up and takes them.
Good summary. Well, all, I hope we get together again. Look forward to the next session.
We will, this time next month. And Dr. Clayman, thanks for joining us. Thanks everyone for going over and spending your lunchtime with us. We'll see you later.